Venous disorders. Venous return muscle pump, peripheral hearts. Ventrathoracic pressure. Arterial pulsation. Vis ergo. Dilated, elongated and tortuous vein of the LL. Varicose veins. Dilated, elongated and tortuous vein of the LL. Problem comes from incompetent calf. 10–20% of world's population have varicose veins. Causes of varicose veins in lower limbs. Secondary. Obstruction of venous outflow. Pregnancy. Fibroids. Ovarian cysts. Abdominal lymphadenopathy. Pelvic cancer, cervical, uterus, ovary, rectum. Ascites. Iliac vein thrombosis. Retroperitoneal fibrosis. Valve destruction. DVT. High flow and pressure. Arteriovenous fistula, ESP. The acquired traumatic variety A.G. Klippel-Trenaunay syndrome, which is one form of congenital avenue malformation syndrome. Primary cause not known. Often familial. Probably weakness of vein wall that permits valve ring to dilate. Congenital absence of valves very rare. Varicose veins, etiology. Primary. Hereditary. Occupational. Pregnancy. Obesity. Secondary. Venous obstruction. Venous compression. AV fistula. Varicose veins, etiology. Obstruction of venous outflow. Pregnancy. Fibroids. Ovarian cysts. Abdominal lymphadenopathy. Pelvic cancer, cervical, uterus, ovary, rectum. Ascites. Iliac vein thrombosis. Retroperitoneal fibrosis. Valve destruction. DVT. High flow and pressure. Arteriovenous fistula, ESP. The acquired traumatic variety. Klippel-Trenaunay syndrome, which is one form of congenital avenue malformation syndrome. Varicose veins. Secondary VV. Primary VV. History. In the age most commonly affect men. Aggravating factors associated with increased incidence of varicose veins. DVT. Trauma. Compression. Fracture. Primary VV. History. Young and middle-aged women most commonly affected. 1:10 Men, women. Aggravating factors associated with increased incidence of varicose veins. Female sex. Parity. Clothing. Prolonged standing. Marked obesity. Varicose veins. Symptoms. Disfiguring effects of the veins. Usually principal complaint. Pain. Dull ache, and heaviness. Felt in calves and lower leg. Worse during day, especially on standing up. Relieved by lying down for 15 to 30 minutes. Edema, swelling around ankle. Aggregated by standing. Relived by recumbency. Night cramps. Disfiguring effects of the veins. Usually principal complaint. Pain. Dull ache, and heaviness. Felt in calves and lower leg. Worse during day, especially on standing up and walking. Relieved by lying down for 15 to 30 minutes. Edema, swelling around ankle. Aggregated by standing. Relived by recumbency. Night cramps. Post-phlebitic syndrome. Dilated veins, venous stars, pigmentation, eczema and ulceration. Varicose veins, signs. Dilated, elongated, tortuous veins. Types of varices. Tubular with dilated LSV or SFV. Secular incompetent perforator, blowout. Signs of PPS, VA. Special testes. Modified Perths. Cough impulse. Trendelenburg's test. Multiple tourniquet test. Schwartz test. Dilated, elongated, tortuous veins. Types of varices. Serpentine dilated tributaries. Spider indicate/V fistula. Signs of PPS plus VA. Special testes. Modified Perths. Cough impulse. Trendelenburg's test. Multiple tourniquet test. Schwartz test. LSV in front of medial malleolus. LSV behind the knee. LSV. Vein of Leonardo. Post-arch vein. LSV behind the knee. Vein of Leonardo. Post-arch vein. LSV in front of medial malleolus. Communicator just below knee. LSV behind the knee. LSV. Vein of Leonardo. Post-arch vein. Vein of Leonardo. Post-arch vein. LSV starting at mid-thigh. Communicator and pass. Behind the knee. Mid-thigh. Communicator. Antramedial in calf. Group of tributaries. Antramedial in calf. Group of tributaries. Examination, inspection, ask patient to stand up. Look for abnormal visible subcutaneous veins. If dilated and tortuous equals varicose veins. Record size and shape of the veins. Venous stars, minute veins radiating from a single feeding vein. Edema. Inspect skin, especially lower medial 1/3 for pigmentation, eczema, ulceration. Examination, palpation. Feel along the course of the veins and feel the tension in the veins. Feel saphenophemoral and saphenophopopliteal junctions and ask patient to cough. A strong cough impulse indicates incompetent valves. Feel along medial side of lower leg for tender defects in deep fascia with patient standing and lying. These are sites of incompetent valves. Look for pitting edema, thickening, and tenderness. Brown pigmentation, eczema and ulceration. Examination, tourniquet tests. Trendelenburg's test. To check for the site of the incompetent valves. Lie patient flat and elevate one leg. Place tourniquet along upper 1/3 of thigh. Ask patient to stand up. If veins fill above tourniquet, the incompetence above. Trendelenburg's test. Direct digital pressure on long saphenous vein valve. Patient first lying with leg up. Stand up patient. Examination, percussion, auscultation. Transmission of percussion waves downward implies incompetent valves. Schwartz test. Place fingers of one hand on lower limit of visible vein and tap top. Auscultation. Listen over clusters of veins, especially if they remain distended when patient lies down, may be arteriovenous fistula. Examination, general examination. Examine abdomen, including rectal and vaginal examination. Men, palpate testes. Testicular tumors can be small but cause massive enlargement of the abdominal nodes with vena-cava obstruction. Look for dilated collateral veins on abdomen. Direction of flow, Harvey's test, empty veins with 2 fingers and see where it fills from. Congenital AV fistula with secondary VV. Traumatic AV fistula with secondary VV. Investigation routine lab, mainly BSL handheld Doppler. Continuous wave Doppler, CWD. Phonoangiography. Investigation. Doppler US. Investigation Duplex US Gold Standard. B-mode ultrasound and a coupled Doppler probe. Allows direct visualization of veins, direction of flow can be recorded. Investigation plethysmography and venography are obsolete. Venous pressure. Radioactive isotope scanning. Arteriography of AV fistula. Complications, hemorrhage, edema, skin pigmentation. Lipodermatosclerosis. Varicose eczema. Venous ulceration. Thrombophlebitis. Atrophy blanche. Marjolin ulcer. Equinus deformity. Varicose eczema. Thrombophlebitis. Treatment. A non-operative management. Walking should be encouraged and prolonged sitting and standing should be forbidden. Patient should elevate leg as frequently as possible to reduce venous pressure. Elastic stockings. Extending from distal metatarsals to just below the knee. Treatment compression sclerotherapy. Permanent fibrotic occlusion of collapsed veins. Patient is recumbent and veins collapsed. A small amount of half a milliliter of sclerosing solution, 3% sodium tetradecyl sulfate, is injected into each varix. Compression sclerotherapy. Continuous pressure is maintained for 1 to 2 weeks with elastic stockings. Much less expensive than surgery. If successful, it gives the best cosmetic result. Long-term results are worse than surgery. Best for small unsightly veins, dilated superficial veins, lower leg perforators, and recurrent or persistent veins after surgery. Unsatisfactory at or above the knee. Endovenous laser perivenous LA 810 nanometers diode, time consuming. Less painful, radiofrequency ablation. Perivenous LA, regional anesthesia. Bode expansion in CFV. Cook at 85 UC. Time consuming. Treatment surgical therapy. Indications, severe symptoms. Very large varices. Attacks of superficial phlebitis. Hemorrhage from ruptured varices. Ulceration from venous stasis. Cosmetic reasons. Treatment surgical therapy. Identify all perforating and superficial veins preoperatively and mark them. Results depend on thoroughness of the procedure. Postoperatively, leg is supported with elastic bandages for approximately 6 weeks. Elevation of leg in bed minimizes post-op swelling. Recurrence rate of about 10%. Most common cause is failure to ligate all the tributaries, and incompetent perforators. External valvular stent. Adjustable Gore-Tex/Dacron cuff. Physiological. Deep vein thrombosis. Only 1/3 of DVTs cause symptoms and signs. Predisposition to thrombosis is predicted with Virchow's triad. Change in vessel wall, distension, injury, inflammation, trauma. Diminished rate of blood flow, during and after operations, post-op rare before 40 years, most common operations, obesity, operations for cancer, prostate and hip, debilitating diseases. Increased coagulability of the blood, infections, after hemorrhage, visceral cancers, during pregnancy, hypercoagulable states, congenital abnormalities of protein C and S, antithrombin 3, deficiencies in the fibrinolytic system. Increased coagulability, diminished rate of blood flow, stasis. Change in vessel wall. Diminished rate of blood flow, stasis. Deep vein thrombosis history, examination. pain and swelling in the calf or whole leg of sudden onset and severe. Walking may be difficult. If pleuritic pain, dyspnea, hemoptysis, collapse. Examination. Swelling. Muscles containing the thrombus may be hard and tender. Homan's sign, pain in calf when foot is plantar flexed. If thrombosis obstructs communicating veins, then superficial veins may dilate and leg feel hot. Phlegmasia albidolens, white leg or milky leg. Phlegmasia caerulea dolens, venous thrombosis blocks all main veins and leg becomes congested and blue. Deep vein thrombosis. Major criteria: history of DVT or family history. Malignancy. Paralyzed or recent plaster immobilization. Recent bedridden greater than 3 days. Operated less than 4 weeks. Thigh and calf swelling. Calf swelling greater than 3 centimeters. Deep vein thrombosis. Minor criteria: trauma to the leg less than 60 day. Hospitalization in last 6 months. Unilateral edema. Unilateral erythema. Unilateral dilated veins. Deep vein thrombosis. High possibility 85%, moderate possibility 33%. Greater than 3 major. Greater than 2 major. Greater than plus 2 minor. Moderate possibility 33%. 1 major plus greater than 2 minor. Low possibility 5%. Others, muscles hard and tender. DVT. Swelling. Muscles hard and tender. Homan's sign, phlegmasia caerulea dolens. Common iliac occlusion with phlegmasia caerulea dolens. IVC occlusion. Prevention of DVT. Before operation, stop pill, if possible 6 weeks before. Grossly overweight patients should reduce weight. Those over 40 should have increased activity 2 to 3 weeks at home. Low-dose heparin. During operation, prevent pressure on venous system. Elevate leg on sandbag, graduated compression stocking or intermittent pneumatic compression. After operation, elevate and massage the leg. After operation, massage, leg movements, graduated stockings, dead stockings, low-dose heparin, adequate hydration, early ambulation. Patients should not sit with their legs dependent, often better to have in bed than sitting in a chair. Prevention of DVT. Methods of prevention. Mechanical, assisting venous return by graduated static compression. Elastic stockings, Kendall's thromboembolic deterrent dead, may reduce incidence of DVT to below 10%, 20% in hip surgery. Electronic stimulation of calf muscles, pneumatic compression. Low-dose heparin 5,000 units subcutaneously 2 hours before operation and continue twice daily until patient is fully ambulating. Avoid if operation will leave bleeding areas or if bleeding in closed space may be disastrous. Low molecular weight heparins, reduced risk of bleeding but as effective. Dextran 70. Inhibits platelet adhesion 500 ml for during operation and 500 ml following 24 hours. Treatment of DVT. Accurate diagnosis using Doppler ultrasound, or venography. Anticoagulation. Aim of treatment is to prevent proximal propagation of thrombus. Before anticoagulation, collect blood for APT, INR and platelet count. Treatment of DVT. Heparin 5,000 units for as loading dose, followed by initially 1,250 units/hour, then adjust according to APTT. Measure APTT every 4 hours and adjust dose accordingly. 60 to 85 seconds is the considered therapeutic dose. When dose is in the therapeutic range, check APTT daily. Check platelets 3 per week for heparin-induced thrombocytopenia. Rare. Treatment of DVT. Cease heparin when warfarin is established with a therapeutic 2 Indian rupees less than for 2 days. Initial warfarin 10 mg orally, once daily for 2 days, on 3-day warfarin should be adjusted according to INR. Continue for 3 to 6 months. Check INR on 3-day, then daily, for first week, then weekly. Treatment of DVT thrombectomy, rarely indicated. Fibrinolytic treatment. Streptokinase, urokinase or combination of streptokinase with tissue plasminogen activator, TPA. Consider in young people with extensive thrombosis. Thrombolysis. Likelihood of substantial thrombolysis is below 50%. There is only limited evidence of long-term benefit. Carries an increased risk of major bleeding. Venous interruption. Extension of life-threatening thrombus, consider venous interruption using filter. IVC filter. Chronic venous insufficiency. Chronic venous insufficiency macrocirculation changes. Obstruction. Muscle dysfunction. Reflux. Increase AVP. Increase perforator. Incompetence. Secondary to DVT. Primary. Physical. Functional. SVI 40%. Combined SVI plus. DVI 40%. DVI 10%. Perforator incompetence isolated in 2 to 4%. Chronic venous insufficiency microcirculation changes. The two most popular current explanations for this process are: fibrin cuff theory. Increased venous pressure will lead to capillary elongation and widening of the pores, giving a chance to fibrinogen to escape and polymerize, creating a cuff that impedes oxygenation greater than ulceration. White cell trapping theory. Decreased pressure gradients slow circulation down and trap the WBCs that marginate and block capillaries. These will liberate oxygen-free radicals and proteolytic enzymes, causing endothelial damage. Chronic venous insufficiency microcirculation changes. Arteriovenous communications. Some suggest the presence arteriovenous shunts, further depriving the skin from oxygen. Trap hypothesis. Some suggest that macromolecules exuded can trap growth factors and cells, rendering them unavailable for regular tissue repairs. Tissue pressure. The benefit of elevation, elastic stocking and corrective venous surgery reduces the tissue pressures and heal the ulcers. Cutaneous iron overload. The accumulation of ferritin can induce production of oxygen-free radiuses, causing tissue destruction. Chronic venous insufficiency. Edema. Skin pigmentation. Lipodermatosclerosis. Varicose eczema. Venous ulceration. Thrombophlebitis. Atrophy blanche. Marjolin ulcer. Equinus deformity. Venous ulcer, the ulcer gator area, lower leg, medial lower 1/3. Edge sloping and pale purple-blue in color. Base being granulation tissue. Tendons and bones may be exposed. Seropurulent discharge, heavy infection and pus is not common. Shallow and flat. Surrounding tissues show signs of venous hypertension, pigmentation, warmth, redness and tenderness. Scars from previous ulcers. Scar tissue may interfere with movement of foot. Lymph nodes should not be enlarged. LSV-CVI ankle flare. Ankle flare. DD of leg ulcer, infective ulcer, ischemic ulcer, traumatic malignant. TB. Dollar. Ischemic ulcer. Traumatic. Malignant. Epithelioma. malignant melanoma, trophic ulcer, DD of leg ulcer, ectyma, traumatic ulcer, symptomatic chronic venous insufficiency or impending ulceration, handheld Doppler examination, suspected DVI, recurrent varicose veins, uncertain diagnosis, short saphenous vein, incompetence, duplex scan, SVI only, SVI plus DVI, superficial venous, surgery, ? Compression therapy, DVI only, functional assessment, venous pressure tracing or photoplethysmography, symptomatic chronic venous insufficiency or impending ulceration, functional assessment, venous pressure tracing or photoplethysmography, no improvement with superficial venous occlusion, significant improvement in refilling time with superficial venous occlusion, superficial venous, surgery, compression therapy, conservative treatment, by scar method, elevation, bandaging, exercises and massage, compression bandaging, multi-layer bandaging for several weeks or strong graduated compression stockings, 40 mm of mercury at ankle. Compression therapy is very successful but ulcers may reoccur. Surgical treatment, ligation and division of incompetent perforating veins, to prevent hydrodynamic forces generated in the muscular compartment from reaching the skin. Surgical or endoscopic stripping of incompetent main superficial systems if they are contributing to the high AVP significantly. Plastic surgery, grafting, perforator subfacial ligation, endoscopic perforator surgery, active or healed ulcers, contraindicated in deep venous occlusion, infected ulcer, treatment deep venous reconstruction not yet standard treatment, can correct primary deep veins reflux but not post-thrombotic reflux or obstruction. Most commonly repaired veins are femoral and popliteal. Done from within. Valvuloplasty, valve transposition or coursing, valve transplantation, Kistner-type valve repair for deep vein incompetence, Palma procedure for deep system obstruction. Lymphoedema, interstitial edema of lymphatic origin, rich in protein. Most common causes: secondary lymph node disease. Causes: primary, congenital or acquired deficiency of the lymphatics, aplasia or hypoplasia. Dilation and incompetence of the lymphatic, hyperplasia. According to age of onset. Congenita since birth 10%. Precox adolescent, 15-35-75%. Tarda greater than 35 years 15%. Causes: secondary, neoplastic infiltration of lymph nodes, infection. Secondary carcinoma. Primary reticulosis. Infection. Filariasis, parasite Wuchereria bancrofti, found in tropical and subtropical climates. This is a cause of severe lymphoedema, elephantiasis, lymphogranuloma inguinale, TB, recurrent nonspecific infection, iatrogenic, surgical excision, irradiation of lymph nodes. Clinical classification: subclinical with histological abnormalities of lane and lymphatic. Grade I. Edema pit on pressure. Swelling disappear on elevation or bed rest. Grade 2. Edema does not pit on pressure. Swelling not disappear on elevation or bed rest. Grade 3. Edema. Irreversible skin changes, fibrosis or papillae. Lymphoedema. History: females, males. Slowly progressive swelling of the limb or genitalia. Lower limb most often affected, often history of trauma several years ago. Not painful and no discomfort. Commonly complicated by athlete's foot, teniopathies, and episodes of cellulitis. Vesicles may appear on the skin that leak clear-colored fluid. Symptoms of underlying cause. Very rare complication of lymphangiosarcoma. Edema does not respond to leg elevation. Examination. Edema est fibrosis. All edema pits, classically said to be non-pitting. Lymphoedema of the lower limb affect the toes much more than other edemas. If it has been present for a long time, the toes become the squared off. Examine the whole patient, especially cardia, renal and abdomen, as well as local, venous congestion, venous thrombosis, as diagnosis of lymphoedema is done after everything else has been excluded. Est fibrosis. The skin on the dorsum of the foot cannot be pinched, stammer sign. Examination. In advanced cases, ulceration ESP if associated CVI rare. Chronic eczema. Fungal skin infection, dermatoptosis. Fungal nail infection, dermatomycosis. Skin gets thick and hyperkeratotic. Thick scales grow outward and look like warts. Ulceration ESP if associated CVI rare. Lymphangiectasia, megalymphatics. Lymphangiosarcoma. Investigation: laboratory pathology, radiology, contrast lymphangiography, isotope-lymphangiography, CT scan, MRI. Management. Goals of treatment is to control the edema and to prevent recurrent infection. Early treatment gives the best results before fibrosis develops and health of skin and subcutaneous tissues are compromised. Management: non-operative management, physical methods, pharmacotherapy. Reduce lymph formation, elevation of the limb. External compression, custom-fitted, elastic stockings worn throughout the day. Sequential air compression devices. Pharmacotherapy. Restrict dietary sodium. Diuretics when edema is being actively treated. Instruction about foot care and hygiene to prevent recurrent cellulitis. Prophylactic antibiotics may be required. Antifungal. Management: surgical treatment. Only needed in a small number of patients. 16%. Indications for surgery. Impaired function. Pain. Recurrent cellulitis and lymphangitis. Lymphangiosarcoma. Cosmetic, although the result will not be a normal-looking limb. Management. Bypass. Microsurgery, axial pattern and microcutaneous flaps and lymphatic and lymphaticovenous anastomoses. Some procedures try to relieve the obstruction by transplanting lymph channels from normal areas.